Welcome back to the Deep Dive, where we take your stacks of articles, notes, and research and distill the absolute core.
Yep, boiling it down.
Today, we're plunging into a topic that is undeniably high yield, particularly here prepping for exams like the MSRA, Lichen Sclerosus.
Yes. LS, definitely one to know.
Our mission, to cut through the noise and equip you with the most critical exam-ready information on this condition. Think of this as your super-focused audio revision session.
That's right. Lichen sclerosus is one of those conditions that often comes up, and understanding its nuances, from presentation to long-term risks, is vital, not just for exams, but for practice, too.
Yeah, it can seem complex.
It can. So we'll break it down, pinpointing the most important facts you need to know.
Okay, let's unpack this right away. At its heart, what exactly is lichen sclerosus?
Well, fundamentally, it's a chronic inflammatory skin condition.
Chronic inflammatory, got it. And location.
That's the crucial point. While it can appear elsewhere, its primary and most impactful site is the anogenital area.
Right, the genital and anal regions.
Exactly. And when we talk about what it looks like, the images that should spring to mind are those characteristic white, often shiny, and importantly, atrophic patches of skin.
Atrophic. That word is key, isn't it?
Absolutely. It means the skin is thin, almost like parchment, which makes it incredibly fragile, prone to tearing.
Makes sense. And who gets it? Is it just older women?
That's the classic picture, postmenopausal women, yeah. But it's really important to remember it affects men and children, too.
Okay, so not exclusively older women.
Definitely not. And historically, it had different names depending on who had it and where you might see sclerosis fulvae for women. Or balanitis xerotica obliterans, BXO in men.
BXO, yes. Heard that one.
Regardless of the name, the underlying process leads to that thinning of the epidermis, the top skin layer, and those distinctive white plaques.
You might also see older synonyms like lichen albus or white spot disease in some older texts, I suppose.
You might, yeah. And a key takeaway. If you see it outside the anogenital area that's extragenital LS, it's generally less common, and importantly, it doesn't cause systemic illness. It stays a localized skin issue.
Okay, good to know. So we know what it is, what it looks like, but the big question, often the most, frustrating one, is why? What causes lichen sclerosus?
That's where the picture gets a bit murky, unfortunately. The exact cause is still unknown.
Still, okay.
Yeah. But research is pointing strongly towards several factors kind of working together. We think it's likely a mix of genetic, predisposition, autoimmune processes.
Autoimmune. That comes up a lot.
It does, and hormonal influences too. Specifically, low estrogen levels are thought to play a role, particularly in women post-menopause.
So it's increasingly seen as autoimmune, maybe triggered in people who are genetically susceptible.
That's the current thinking, yes. And it fits with the known association with other autoimmune diseases like thyroid disease and vitiligo.
Oh, interesting. Does that thyroid link apply equally to men and women?
The link seems stronger in women, actually. And if you see a patient with a family history of LS that's relevant, it pops up in about 10–12% of cases.
Okay, 10–12%.
Yeah.
Worth asking about. What about in men? Any specific links there?
Yeah, in men, the associations mentioned are slightly different, more systemic things: increased BMI, coronary artery disease, diabetes, and smoking.
Oh. Broader health links.
Exactly. And beyond those, local factors are debated too, things like preceding infections, trauma to the area, maybe even just a persistently moist environment. Though the role of specific infections like Borrelia is still, debated, not fully clear.
Right. So if we boil all that down, who should we be particularly thinking about LS for?
Yeah.
What are the main risk factors?
Okay, the key risk factors that sort of jump out are female gender, being postmenopausal, those lower estrogen levels, having a family history, having other autoimmune conditions, and maybe some of those local factors or infections, though the evidence varies a bit there.
So recognizing these is crucial, especially in primary care.
Absolutely crucial. Maintaining a high index of suspicion based on those risk factors and the symptoms we'll discuss, that's often key to catching it early. And for the MSRA, knowing these specific associations is definitely high yield.
Right, so how does this mix of factors actually lead to the skin changes? What's happening, like, on a microscopic level?
Okay, the pathophysiology. It seems to revolve around this autoimmune process, targeting components within the skin.
Targeting what specifically?
It specifically attacks and destroys elastic fibers. Those are the crucial bits that give skin its normal stretch and flexibility.
So it loses its stretchiness.
Exactly. And at the same time, you get abnormal collagen deposition. This is more of a rigid, fibrous type of tissue building up.
So the normal, flexible structure gets replaced by something stiff and fragile. Like replacing rubber bands with brittle twigs.
That's a pretty good analogy, actually, yeah.
Yeah.
The immune dysfunction triggers chronic inflammation, and the end result is that gradual replacement of healthy elastic tissue with this dense, inelastic, thin, sort of scar-like tissue.
And that's what causes the atrophy. The thinness, the fragility.
Precisely. And makes it prone to tearing and developing those characteristic white plaques. The skin scaffolding is attacked and then repaired, but with faulty materials.
Okay, this is a really big one for the exam, and for practice too. When someone presents with white patches, especially down there, LS isn't the only thing it could be. We absolutely have to think about the differential diagnoses. There's quite a list, isn't there?
Oh, definitely. And this list is critical for the MSRA. You need to be able to tell LS apart from things that look similar, but maybe even more importantly, tell it apart from things that are pre-malignant or even malignant.
Okay, hit me with the key ones.
Right, so you've got vitiligo, that's loss of pigment, but the skin texture is usually normal.
Texture's different, okay.
Candidiasis, so thrush, an infection. Localized scleroderma, also called morphea, that's hardened skin.
Right, scleroderma.
Then lichen planus, another inflammatory one, often more purplish or erosive. Lichen simplex chronicus, that's thickened skin from chronic scratching. Leukoplakia.
Which can be premalignant.
Exactly. Vulval intraepithelial neoplasia, or VIN, Bowen's disease, which is essentially squamous cell carcinoma in situ.
SCCs in situ.
It's sometimes called erythroplasia of Queyrat in men. Graft versus host disease, maybe after a transplant. And psoriasis.
Wow, okay, that is a list.
Mhm.
Maybe grouping them helps for revision. Like you've got inflammatory mimics, lichen planus, psoriasis,
Yeah.
infectious candida,
Mm-hmm.
autoimmune or sclerosing things, vitiligo, scleroderma, GVHD.
Good way to think about it.
But the really crucial ones to differentiate, often needing that biopsy, are the premalignant and malignant ones. Leukoplakia, VIN, Bowen's.
Precisely. Being able to distinguish LS from VIN or Bowen's is absolutely paramount because of that risk of progression to invasive squamous cell carcinoma. Clinical vigilance is key there.
So how common is this condition, actually? Do we have any numbers?
We do. It's not the most common skin condition overall, but it's surprisingly prevalent in certain groups, particularly common in women, especially after menopause. Estimates suggest a prevalence of maybe around 3% in adult women.
3%. So like 1 in 30 women over their lifetime might experience this. That's higher than I'd have thought.
It is. It means you will see this in primary care. In men, though, it's significantly less common. Prevalence is more like 0.07%.
Okay, big difference.
And if you look at incidences across age groups, you see peaks in prepubertal girls and postmenopausal women, and similarly in young boys and adult men. So it's not just a condition of older women, even though that's where it's most frequently diagnosed.
Got it. So walking into the clinic, what does a patient with LS actually look like? What are the classic signs and symptoms we need to spot?
Well, the clinical picture is often pretty distinct, though it can vary. The hallmark, as we said, are those white, shiny, atrophic patches. But what usually brings patients in are the symptoms.
The itching.
Yes, severe itching pruritus. Especially bad at night, that's incredibly common and often the very first symptom people report. It can be really debilitating.
And that thin, fragile skin, tearing easily must be awful.
It is. Soreness, pain, fissuring those little cracks, and bruising from even minor trauma are really frequent complaints.
And in women, if it goes on, it can actually change the anatomy down there.
Yes. Severe or long-standing disease can lead to significant architectural changes due to the scarring. You can see loss of the labia minora, fusion or scarring over of the clitoral hood, narrowing of the vaginal opening, the introitus.
Which must have huge impacts on quality of life, sex life, even just peeing sometimes.
Absolutely. Major impacts. In men, it most commonly affects the glans, penis, and the foreskin. The big issue there is often phimosis.
That tightening of the foreskin.
Exactly, making retraction difficult or impossible. That causes discomfort, especially with erections, and can make hygiene difficult.
And extragenital LS, what does that look like?
Similar presentation, just elsewhere on the body. Typically itchy white patches. Less common, though.
Okay, let's paint a picture. Mini case time. Imagine you're seeing, say, a 68-year-old woman complaining of really intense vulval itching for months, worse at night. She says the skin feels thinner, tears sometimes. On exam, you see some shiny whitish patches. Maybe some areas look a bit fragile. What's shooting to the top of your differential diagnosis?
Lichen sclerosus, absolutely. That combination, postmenopausal woman, severe itch, especially nocturnal, those characteristic skin changes, highly suggestive.
Okay, so we strongly suspect LS. How do we confirm it? Do we need loads of tests?
This is a really key point for the MSRA. The diagnosis of lichen sclerosus is primarily clinical.
Based on what you see and hear.
Exactly. Based on recognizing those characteristic signs and symptoms during the examination, you don't always need a biopsy.
Okay, so when do you biopsy?
You'd consider a biopsy in specific situations. If the diagnosis is uncertain, maybe it looks a bit atypical. Crucially, if you suspect malignancy, that's a major reason. Or sometimes to check treatment response, although that's less common routinely.
And if you do biopsy, what are the pathologists looking for? What are the key features?
The characteristic histology includes thinning of the epidermis, loss of those ridges, the sort of wavy bits between epidermis and dermis,
Right.
and a band-like infiltrate of inflammatory cells, mainly lymphocytes, sitting just underneath the epidermis. Seeing that pattern really helps confirm the clinical picture.
What about other tests? Swabs, bloods.
Swabs are generally only needed if there are erosions or fissures and you think there might be a secondary infection like thrush, making things worse or stopping healing.
Makes sense.
And routine blood tests for hormones or autoantibodies, generally not indicated unless the patient have other signs or symptoms strongly suggesting an associated autoimmune disorder. There's no screening blood test for LS itself.
Right, so clinical diagnosis first, biopsy if needed for specific reasons, other tests only if clinically indicated.
Got it. So once we've made the diagnosis, how do we manage it? What are the main goals? Okay, management goals are pretty clear. Alleviate the symptoms, especially that awful itching and soreness. Prevent the disease progressing and stop complications like scarring. And really importantly, monitor for associated conditions, especially malignancy.
And the absolute cornerstone, the first-line treatment according to guidance, it's topical steroids, right? But strong ones.
Exactly. For active or more severe disease, the go-to is typically an ultra-potent topical corticosteroid. Clobetasol propionate 0.05% is the classic one.
Clobetasol.
For milder disease or maybe for maintenance once things are under control, a potent steroid like mometasone furo 0.1% might be used instead. Treatment usually starts with a reducing course, apply it often initially, then tail it off as symptoms improve.
And this isn't usually just a quick fix, is it? You mentioned it's chronic, so maintenance is often needed.
That's a critical point. LS is chronic for most adults. Stopping treatment completely often leads to symptoms coming back and the scarring progressing. So yes, patients often need long-term maintenance therapy. Maybe just applying the steroid once or twice a week, long-term, to keep the inflammation suppressed and the condition under control, especially for anogenital LS in women.
What if the steroids aren't enough, or maybe the patient gets side effects? Are there other options?
Yes, there are. Topical calcineurin inhibitors like pimecrolimus or tacrolimus can be effective.
How do they work?
They suppress the local immune response, but in a different way to steroids. So they're a useful alternative, particularly if steroid side effects like skin thinning are a big concern, though they can sometimes cause burning initially.
Any other options for really tough cases?
For very severe or widespread disease that just isn't responding, you might consider intralesional steroid injections, triamcinolone injected right into the affected skin, or even systemic treatments like oral steroids, methotrexate, cyclosporin, or retinoids. But these are definitely reserved for specialist management.
Okay. And beyond the prescriptions, what else can patients do? General advice.
Oh, patient education is massive here. Simple things like gentle skin care, using soap substitutes, avoiding harsh scrubbing.
Avoiding irritation.
Exactly. Avoiding tight clothing can help reduce friction. Addressing any incontinence issues is important too, as moisture can aggravate things. And really crucial education is about making them aware of that malignancy risk.
What signs should they look out for?
Any new lumps, any ulcers that don't heal within a few weeks, or any significant changes in skin texture or color that seem different from their usual LS, they need to know to report those promptly.
Okay. And for men, if they have that significant phimosis and the steroids haven't helped?
Then referral for circumcision is often the necessary next step to relieve the symptoms and prevent further problems like urinary issues.
And follow-up. How often do these patients need checking?
Long-term follow-up is definitely recommended, especially for women with anogenital LS, and particularly if they're using long-term steroids. Maybe annual reviews are enough for stable patients on minimal treatment, but it needs to be tailored.
Then you mentioned photos.
Yeah, taking clinical photographs can be really helpful. It gives you an objective way to track the appearance over time, monitor treatment response, and spot any subtle changes early. Good for the patient to see progress, too.
Okay, let's do another quick MSRA-style question on management. A 60-year-old man diagnosed with penile lichen sclerosus.
Yeah.
He's got significant phimosis, causing discomfort. He's used potent topical steroids as prescribed, but the phimosis hasn't really improved. What's the most appropriate next step?
Based on what we just said,
Yeah,
if the phimosis is significant and hasn't responded to a good trial of potent steroids, the next step is referral for consideration of circumcision.
exactly. Highlights that sometimes medical treatment fixes the inflammation, but you still need to address the structural consequences, like severe phimosis, surgically.
Precisely. It's treating both aspects.
So, looking long-term then, what's the prognosis? If someone gets diagnosed, what can they expect? Is it curable?
For most adult women, unfortunately, it's generally considered a chronic condition. It needs long-term management rather than being cured in the traditional sense.
But the outlook for symptoms is good with treatment.
Yes, with proper management, the prognosis for symptom control is generally very good. Treatment can dramatically improve the itching and soreness and, crucially, prevent further scarring.
But you mentioned the scarring that's already there.
Yeah.
That doesn't go away.
No, sadly, established scarring like labial fusion or severe phimosis generally isn't reversible with medication alone. That's why catching it and treating it early, before those changes become permanent, is so important.
Are there any groups where it might actually resolve?
Yes. Interestingly, there seems to be a higher chance of spontaneous remission in children diagnosed with LS, particularly girls around puberty, though maintenance treatment might still be needed sometimes. And men also tend to have higher remission rates with treatment compared to women.
And you said symptom remission rates with the potent steroids are high.
Very high, yeah. Studies suggest around 98% symptom remission in women who use the potent topicals correctly and consistently. Remission is also possible in men with steroids or, as we said, circumcision. But the catch is recurrence is always possible if maintenance treatment isn't kept up.
Right. And the big shadow hanging over the long-term prognosis, that malignancy risk again.
Absolutely. This is the most crucial aspect of the long-term outlook and why that follow-up is non-negotiable. There is a definite, albeit small, lifetime risk of developing squamous cell carcinoma, SCC, within the affected areas of LS.
How small is small?
Estimates vary a bit, but it's often quoted in the region of 4–5% lifetime risk for both sexes with anogenital LS.
So not huge, but significant enough to warrant lifelong vigilance.
Exactly. Extragenital lesions are much, much less likely to develop SCC and often have a better chance of cure, but those anogenital lesions need careful watching.
Okay, so let's just recap those potential complications in a bit more detail, especially the ones from long-standing or severe disease.
Right. So most complications in the anogenital area stem directly from that scarring and atrophy. In women, it's the architectural distortion. Labial fusion, burying of the clitoris under scarred skin, narrowing of the vaginal opening, leading to pain during intercourse dyspareunia and significant sexual dysfunction. Severe narrowing can even cause problems with urination, like a slow stream or spraying.
And in men.
Primarily that severe phimosis making retraction impossible, affecting hygiene, causing pain with erections, potentially leading to urinary retention in severe cases.
And then looming over it all, the SCC risk.
Yes, development of squamous cell carcinoma is the most serious long-term complication. Any non-healing ulcer, any new lump, any persistent area of thickening or redness within the LS patch needs urgent assessment and likely biopsy.
Are there other, maybe less dramatic complications, like bowel issues or nerve pain?
Good point, yes. If LS affects the perianal skin, it can cause painful fissures, leading to constipation because people avoid opening their bowels. Managing that with laxatives is important.
And nerve pain.
Dysesthesia, yeah. Some patients experience a burning or tingling neuropathic type pain, even when the skin looks relatively okay. That might need specific treatments like topical anesthetics or even drugs for nerve pain if it's bad.
Anything else?
Occasionally, a clitoral pseudocyst can form under scarred skin, basically trapped secretions, which might need referral if it gets painful or infected. And underlying all of this is the huge potential impact on quality of life. The chronic pain, the itching, the sexual difficulties, the psychological distress. Referral for psychosexual counseling or support might be really important for some patients. Managing LS often involves tackling these specific complications as they pop up, alongside treating the underlying skin inflammation.
Wow. We have covered a huge amount of ground there. From the definition, those white atrophic patches, through the causes, the pathophysiology, the differentials, how common it is, what it looks like, diagnosis, and crucially, management with potent steroids and the need for long-term follow-up. especially watching for that SCC risk.
Yeah, hopefully this gives everyone listening a really solid, high-yield foundation for their MSRA revision. Remembering those key clinical features, the importance of potent topical steroids as first line, the differential diagnoses including malignancy, and the absolute need for long-term monitoring. Those are the core takeaways.
As we wrap up, it really strikes me how a condition like lichen sclerosus, often affecting intimate areas, causing symptoms people might feel embarrassed about.
Yeah.
It just highlights how vital it is to take a really good history and do a thorough, sensitive examination.
Absolutely.
Spotting those early, maybe subtle skin changes can genuinely prevent years of discomfort and potentially life-altering complications, like severe scarring or, worst case, malignancy.
It really underscores the importance of vigilance,
Yeah.
particularly in primary care for conditions that might seem hidden.
Definitely. Well, that's our deep dive for today. For more free MSRA revision resources to help you prepare, do visit freemsra.com.
And for the full premium revision toolkit, head over to passthemsra.com.